the hematologists have understood a long time ago that they had to look at the biology of the disease and try to understand which were the driving mechanisms that were modifying the cells. And of course, everyone knows about the history of the development of the treatment of chronic myelogenous leukemia, and since then we have had similar examples in chronic lymphocytic leukemia and some lymphomas. So the reality of a treatment that is directed by the biology of the disease and that is very often, not always, remarkably well tolerated also by the older patients, those that have several comorbidities, is true now in hematological oncology. Older patients have several comorbidities, and this can sometimes affect the use of some of these new agents because of drug-drug interactions. This is something relatively new, certainly in solid tumor field, and I'm certain that my colleagues in hematological malignancy field have started now to understand that we have to deal with this, and we have to deal with some specific side effects of these drugs, and also improve on the use of standard cytotoxics with appropriate supportive care. The progress in the treatment of CML, CLL, the different lymphomas, and certainly multiple myeloma is staggering. The side effect profile of most of these drugs is relatively well controllable. However, you have to pay attention for some of these agents to endocrine interactions, to potential heart issues, to skin issues, but all of that can be controlled quite well as long as you know how to manipulate the drug. If we think of multiple myeloma, one of the areas that has been now recognized is the importance of control also of the bone environment. And the initial data that has been shown a few years ago, first in clodronate and now with zoledronic acid, with the last study of the MRC showing an impact on patient survival when you use appropriately zoledronic acid, is extremely important, and we look forward to further data with the newer agents which have not yet been fully studied in the setting and need to have more study. The issue that we face today with this fantastic development is that it does cost a lot to develop a new drug. That is certainly something that we have to recognize. But on the other hand, it is then an issue to pass on those costs to the society. And we have to find a good solution in order for those that have developed these drugs, mainly drug industry, and the payers to find a way of giving the so-called return on investment, but at the same time allow society to afford some of these new drugs, which otherwise will become an unacceptable burden for society. The issue of drug acceptance or not acceptance by different authorities is extremely complex, and I think that we have to work hand in hand between the physicians, the authorities and industry to find a solution. Certainly when a drug does not really modify the long-term disease outcome. And by this I mean that some drugs might not seemingly affect the patient's survival because the study doesn't show that, but actually if you do get a long remission and then you have another drug that again gives you good remission, at the end you will have an impact on survival, and this is something that has to be looked at. On the other hand, society certainly cannot pay up to a certain amount in order to improve the survival of the population. And that's where it's a very delicate balance. But we should avoid simplistic approaches, and I'm sorry to say I think that some of the approaches have been somewhat too simplistic, looking at the impact in some studies and not looking at the overall impact within the field of that particular drug. And an example in solid tumors has been the debate in the setting of colon cancer, where you're not affecting survival, but we have now shown that second, third, fourth line treatment at the end have increased the survival of colon cancer patients from 1.5 to 2 years to 4.5 to 5 years.